screen. This doesn't seem to have.
I think in PDF, is it
a full screen, right?
Should be possible, but it's not giving an option, I think.
It's not giving me an option for full screen.
So it's fine, Doctor. I think we've already lost a lot of time, and it'll be good to just move forward. Okay. So, and thank you for the warm introduction and the welcome. I really appreciate it. And I'd like to share a few things about what USAID is doing. I know that Doctor mentioned a number of areas, but I will restrict myself to the health office because that's where we do the most work. There are, of course, a number of other areas, and maybe we could save that for another time. Next slide, please. So I'll direct your attention to the box on the right, which basically talks about the areas that we work in. Firstly, preventing child and maternal deaths. That's our big portfolio, and we have been working for a number of years. And maybe I think before I get in here as background, USAID has been in India for over 70 years. We are not yet at 75, but a little after India's independence was when we set up office here. In addition, we are located at the US Embassy in Chanakyapuri here. We also have consular offices in Mumbai, Chennai, Hyderabad, and Kolkata. And those areas are mainly to support visa applicants and visa-related issues. But here at the embassy, USAID is also situated, as does the CDC and the NIH and other organizations that you may be more familiar with. USAID is the lead agency for the United States government to work in the development space. So the full form of USAID is the United States Agency for International Development. And that's really what we do in trying to support governments, accelerate their efforts to address key and important areas that will help move the needle as far as its development plans are concerned. So, as I think we've lost the PowerPoint, Doctor, if someone's looking at it. I'm fine. I have my own, but the others who are listening in may not be able to see the PowerPoint.
It should be visible now?
Yes. Now it's fine. So coming back to draw your attention to the right side of the screen. The first one was preventing child and maternal deaths. Second is championing a TB-free India. And that's where, I've done a lot of my work and, continue to do so. Preventing HIV/AIDS, strengthening health systems, which all of you all know is a challenge, and, a large part of research and research-related activities come under there. And of course, now we've started moving into the global health security agenda space to try and help the government shape that. If we work the way we function by and large, and very little is out of this, what we normally do is we engage with the government. We try and understand through interaction with them in terms of what is their challenges or gaps, and where do they think that we can come in and provide support that will help move the needle for them. Remember, our monies are very small, so we cannot substitute what the government is doing, and we don't want to do that. What it really is that, so for example, I'll give you an example. If we'll take a district or two in a particular state, we'll figure out a particular activity in conjunction with the local health authorities, and then we'll use the local health authorities personnel to implement the activity in those two districts. We may have a few people there, but that's about it. Rest of it belongs to the government system, and we use the government system to implement. If it's successful, what we then ask the government is to add their budget in the coming years for the rest of the districts. And then we support the other districts in the coming years to be able to implement the same activity. So at a given point in time, the whole state is covered. Simultaneously, we work with the national counterparts of those particular areas, say TB, HIV, family planning, MCH, whichever, at the national level, and they help to roll it out countrywide. And that's how success is built. If it fails, then it stops with 2 districts, and then we just exit. So, all failures are on us, and all successes belong to the government. So that's really the way we function. And some of the counterparts are mentioned at the bottom of your screen. With the Ministry of Health and Family Welfare, that's our biggest, partner. Then, of course, Niti Aayog, NACO, various state governments. Then outside, you have Global Fund, WHO, all the UN organizations. And on the ground, it is the NGOs and CSOs who make the difference to be able to actually take, whatever you're thinking at national level down to the last mile. Next slide, please. So just as I mentioned, 70 years of programming, and we've actually transitioned from being a donor now to being a trusted partner of the government. Our budget in health is roughly about 50 million, give or take. But during COVID, we got an additional $200+ million without any additional staffing, and all of us had to pitch in and do double time and double duty to be able to support the government address COVID. And we do all of this by trying to engage not just international partners, but also building capacity of local organizations so that, we leave the area better than we found it, wherein we have strengthened local Indian organizations that can support the government in the long term. Next slide, please. So, our key approaches really is about sharing innovative, evidence-based health practices. And we look to invest in local systems, like I just mentioned, that enables ownership of the country and, their ability to both speak the language, know the terrain, and provide services in the local area. We also emphasize scale. I already discussed that. It's about demonstrate, operate, and then transfer, so that the benefits are actually scaled across the country. Maximizing private sector has always been something that we're looking at. It's always a challenge to try and engage at both ends, both public and private. But I'll talk about it a little later in terms of how exactly we can engage with the private sector and what it is we can do. So what you see as the bullets there, it's about innovative financing, raising private capital to support health outcomes, and then create and engage private sector platforms. And we've built a few platforms so far that enables small amounts of money from multiple people to create maximum benefit for the problem that's trying to be solved. And then, of course, putting inclusive development at the core of programming, focusing on vulnerable groups, and it could be anybody in the urban poor, youth. India is the largest youth population. Engaging with them, tribals. For those of you all who don't know, there are 100 million of the population have some tribal connect. Over 184 districts across the country have been designated as tribal populations, and they are part of the most downtrodden and have difficulty in accessing services, let alone getting the benefits from them. So these are areas that we generally go through, and USAID has always been at the forefront of anything to do with gender, inclusivity, divergent communities and their behaviors, and including all of them. So women and girls are a top priority to ensure that in everything we do, we always have, as far as possible, equal share amongst the genders and sexes to be a part of the activity. Next slide, please. So I'll just go through quickly just a couple of slides on each of this. So we'll start with family health, where we'll talk about child and maternal deaths. Next slide, please. So, why are we working in family health? And, these bullets will drive the point home. 10% of global maternal mortality and 20% of global under 5 mortality is in India. 32,500 mothers and 1 million children die every year. Over 700,000 are newborns who die in their first month, and nearly 18 million of the country's annual pregnancies are unintended, and 16 million are poorly spaced. Like I mentioned earlier, we have the world's largest youth population, 30%, and 27% of women aged 20 to 24 were married before the age of 18. This is an area where services are generally either shunned, refused, difficult to reach, simply because, that's the context in which we live. So it's really a challenging environment to be able to reach out to these women and mothers, and especially the newborns. Next slide, please. So in this space, we are working mainly in 7 high-burden states and 25 aspirational districts. You can see the states outlined there, mainly the central belt of India, where, we have a lot of these challenges. We are expanding, but, for the government, this is where they have requested our support. And hence, like I mentioned earlier, because we work closely with the government, this is exactly how we work with the local state governments. Next, please. So on the ground, we have about 15 partners, and, just a quick snapshot of what we do at national level and state level. One is, of course, to support global priorities. So every newborn action plan and sick and small newborn care. We have a technical support unit called Lakshya, and we have an aspirational district program unit that we're supporting. We provide technical support to formulate the national guidelines, and that there are a lot of them that are there. And then technical assistance to shape Gavi's investments in India for improving immunization coverage and new vaccine introduction, and for the polio endgame strategy. I think at this point, maybe I'll just state that almost 40 to 50% of Gavi funding comes from the US government, as well as about 30 to 33% of the global fund funds are from the US government. So we have a lot of play in country despite having multiple sources of funding. And then, of course, inclusion of high impact interventions to the national program. Many of you have probably been on various teams that have engaged in these areas: kangaroo mother care, family participatory care, and respectful maternity care, just to mention a few. So these are all the things that are happening at national level. But to help implement this at state level was what I mentioned earlier. So we're looking at, quality improvement initiatives in the public and private sector. So you have care around birth. There's something called Utkrist, which is a DIB, a Development Impact Bond, and Vistrit, another project. Innovative demonstration models and scale up. A lot of it in COVID. So pulse oximetry, handheld Dopplers, kangaroo mother care, etc. Innovative models for using data for action. And I think, that's the big area that, where everyone's looking for support, and, how we can provide that support to the government. And then technical assistance to improve MNCH outcomes in the 25 aspirational districts. So, high risk pregnancy tracking, and, various other things that we have there as part of that. Dr. Aradhita, we have some questions. Do you want to take them now, or do you want me to take them later?
We'll take all the questions at the end of the talk. Okay. Please keep typing in your questions. We'll address them at the end. Thanks.
Excuse me. Next slide, please. So, some of the highlights in family planning. We support the global priorities such as Family Planning 2020, which is now Family Planning 2030. Technical support to the National Adolescent Health Programs, school health programs, amplifying the youth voices, market shaping and expansion through initiatives such as the Condom Alliance. There's actually an Indian Condom Alliance now, to help, move the needle on activities in that space. We have a strengthened gender-based violence program. The first ever campaign is actually an intimate partner violence that we have taken on. And we always advocated for volunteerism with strong compliance monitoring. So, nobody's forced into anything. It's always voluntarily done, but the options are provided. At state level, the number of innovative tools, and I know the word innovation has been much maligned and abused, but I'll give examples of innovations as we move forward so that you are aware. So, there are chatbots, there is Digi Assistant, there are workplace interventions that we're looking at to help innovatively support expansion of this. And like I mentioned, expanded basket of choices with new products being introduced and using advocacy to scale them. Community engagement has been a big factor for us. Despite the top-down approach, we also have bottom-up, which is what the community voice is about. And then, we'll support the government occasionally in supply chain and reduce stock out, especially in family planning products, if required. And then, of course, improve the quality of services to both public and private. Next, please. TV. Next, please. So TV, for many of you all who have not worked in that space or have a sense of it, there are over 2.6 million new cases of TB every year, right? So I'll stress that again, 2.6 million new cases of TB every year. India has the world's highest incidence of both TB and drug-resistant TB. 25-26% of all TB cases are from India. And shockingly, we still have over 400,000 TB-related deaths every year, despite all the progress that we've made. Like I said, over 1/4 of the burden of both the DRTB and drug-sensitive TB. We have been working for over 25 years with the government of India, and a number of changes have been made, but we still, all of us need to be worried that even after a 1/4 of a century, we're still having 400,000 deaths every year. Next slide, please. So this is one of our larger portfolios. We have about 40 partners and sub-partners. We have a wide area because we work closely with the Central TB Division. We work in a number of select districts based on what the government would like to see. And I mentioned the model earlier in those various states. Also the tribal districts. It is now 184 from 161. At the national level, we have technical support units that support drug-resistant TB, artificial intelligence solutions, as well as tribal that I had mentioned. Vulnerable communities, how do we enable training and capacity building and ensuring that they're providing support at the ground. We also set up this corporate TB pledge, wherein I think today there are over 215 corporates who are willing to support TB and TB-related activities, either through workplace interventions or supporting patients in their area of where either their factory or their office is located to ensure that those patients get the benefit. And then, technology is always there, that's happening. But I draw your attention to what's happening at state level, where we help to both enable diagnosis as well as treatment. We do active case finding drives, build the capacity of communities, and especially TB patients, a number of them, need, say, for example, skill building. So we're able to attach them to institutes that support that. People who are willing to support newer TB patients, after they are cured, we call them TB champions, and we build their capacity to have a voice in the community, try and, wash away the stigma that's always there with TB. In research, I think, which may be of interest for you all is mainly operational research, behavioral research as well, but operational research because the government is always looking for evidence so that, that they use that evidence to operationalize activities. So as opposed to basic research, we do a lot of operational research. And then, of course, innovative financing, pay for performance, for example, various types of bonds, looking to get multiple people to fund. We have a project now that, we are funding 10%, 90% of the funds are coming from the private sector. And the activity, the the organization implementing the activity is paid based on results. So we're seeing a lot of traction, and for us, we're able to convene and bring people together, put in a small amount of money. The others also get the benefit because of their leverage on what we bring, and of course, their resources. Next slide, please. Global health security. Next, please. So, the global health security is huge, and many of you all would have probably heard of One Health, which is basically human health, animal health, and environmental health. And as you all are probably aware, each one of those are separate and multiple departments within the government of India. So, it's going to be a challenge to be able to bring all of that together. But in our own small way, we started working in the emerging infectious diseases, or EIDs, to be able to start looking at pandemic preparedness based on what we've seen in COVID. Antimicrobial resistance has a normal leaning towards health simply because of the antibiotics, but we're also looking at antibiotics both in farm use as well as in animal use, and how that gets translated into food that people consume. So invariably, you are consuming some form of chemical despite eating, let's say green foods, for example, right? And then, of course, looking to support various parts of, say, the NCDC, National Centers for Disease Control, working with other organizations, the Food and Drug Administration, World Health Organization, UNICEF, all of these organizations will come into play. And GHSA is slowly building to be a large portfolio. But at the moment, we're playing it small, and we're just working our way through the government to be able to understand how they would like to address the GHSA and One Health in general. We have some new projects at the bottom, right? And one challenge we have is we don't have direct funding at the moment, but we sustain our work through WHO and other organizations that we fund, for example, through TB for antimicrobial resistance. So over time, we should be getting funding for this activity, and we hope to then expand in terms of what the government would like to see on the ground. Next, please. So I'll just take a couple of minutes, and I'll watch time because I would like to answer, your questions. COVID-19, hit so badly that it was really hard to be able to even understand what can be done. What's the magnitude of the problem? But overnight, the amount of money we received is what we normally receive in 10 years. So just imagine that you have to plan and execute activities that you'd normally take, 10 years or an over period of 10 years to execute. You suddenly got to do it overnight. And this was what happened. And I think, here are just some of the results. Almost 125 million people were reached, with more than 18 million people receiving vaccines. And supporting mainly the vulnerable populations, not so much the healthy, or let's say the more urban or areas that most of you all would have gone to get vaccines, but the difficult to reach, last mile, the flooded areas, the tribal areas. You had issues, for example, in tribal areas where, if you're not aware, they actually have a union of traditional healers. And until the traditional healers did not give permission for vaccines to be provided, you could not give vaccines to the tribal population. And so, in addition to actually having the vaccines on hand, there were a number of issues that were there, right? And in all of this, you still had to train healthcare workers and ensure that they're doing the right thing, right? So, over 160,000 healthcare workers were trained, almost 18,000 health facilities supported. We actually set up over 600 oxygen generation plants, and provided the technical assistance on how to use them. It's a different matter that now, the government is coming back to us and say that now that the 600, we don't require that many, how do we use that? So, so alternate means are now being looked at. Expanded the reach of the health system through tech solutions. So, IVRS, telemedicine, e-solutions of, so for example, drug delivery, and things like that, were all taken up. And then, policies and guidelines needed to be rolled out almost every night. There was some new directive that was coming out from the government. So they needed support on someone who could write it and then move it through the system for approvals and get that done. Risk communication and community engagement was a big challenge because, the community was ready, but there was nobody to tell them what needs to be done and how it could be done. So, over 161,000 of them were trained on it. And then, also the various resources that were coming in, how do you mobilize that and use that for innovations? So, in addition to the 200 million that we had put in, we almost raised another 250 million through various sources to support that. And, we developed a caring CEO forum from over 200 corporations. And, the corporate houses were kind enough to step up when needed. And I think, what really stood out at the end was almost 10 million vulnerable populations were reached. I think, the World Economic Forum actually recognized India in the top 50 as having reached the last mile, which was really how we were able to significantly save a number of lives that, the country was heading towards. Next, please. HIV. Next, please. So, the context, India is the country with the world's second largest number of people living with HIV. The country is doing a fabulous job in able to reduce and maintain, the low levels of prevalence. Noticeable reduction is the number of AIDS-related deaths. That's a 66% decline since 2010, which is way above the global average of 39. And so for every 100 HIV-infected people identified at testing, 88 are initiated on treatment. So there is still a large gap that needs to be filled. Still 2.3 million people are HIV positive with 190 new infections every day. And India's program is one of the 12 PEPFAR Asia regional programs, which USAID supports in the region. Next, please. So, again, we have limited geography where we work in as far as HIV is concerned. But, looking to see how we can fast track the government's 95, 95, 95. You can see that, we are still lagging behind. In certain areas, it's only at 76, 84, 84. But I think that gives us hope that, there are a number of other countries globally that are, way behind. But I think India is doing well. Of course, there's always room for improvement. Next, please. So we have about 6 partners, and we're looking at mitigated treatment interruption. Mitigating treatment interruption with a mix of prevention and responsive interventions. There are community clinic and pharmacies, we call them TAL or TAL Plus, to provide integrated services. We provide protected referrals and services through virtual platforms. And this has been a game changer in a number of areas. People are still stigmatized, but these virtual platforms have enabled people to actually come out in the open and seek help and seek services. Collaborated with community and, made this technology available to community leaders. So, while maintaining the confidentiality, services are also being provided. And looking at newer areas of strategic purchasing for HIV through an SFI, Sustainable Financing Initiative. And, we look to scale this up like we always do for other things. Also collaboration, prevention and treatment partners for bidirectional referrals for orphans and vulnerable children. A number of persons have been lost in HIV, and they leave behind children or elderly and who need support. But mainly orphans and vulnerable children is an area that we are specialized in. And then various funding streams, we are coordinating that to help maximize gains. Next, please. Health system strengthening. Next, please. So, we're all aware of the acute shortage of health professionals. Nothing new. It's the size of our population. It's always going to be a challenge. There's always, suboptimal healthcare, especially at primary care level. And 8 out of 10 nurses are trained in private institutes, and many of them also seek employment outside of the country. So, that's, one large gap that is there. Second one is, over 40 million people fall into poverty due to out-of-pocket healthcare expenditures. All of you are aware that we do not have adequate outpatient healthcare that is, available through an insurance system. Insurance pays only if you're admitted for at least 24 hours, right? And so invariably healthcare in India is out of pocket, which puts a huge strain on burden on finances that a family may have, right? Less than 2% GDP is spent by the government on health. All of you are aware of that. And unfortunately, 10% or thereabouts of the National Health Mission budget lies unspent every year. Private sector is largely unregulated. 70% of healthcare is provided by private sector, and to a large extent as the first point of contact. And most investments of the private sector are in the secondary and tertiary care and not in primary healthcare. So this is kind of the context and what you're dealing with in trying to support the health system. Next, please. So we use, the expertise of about 6 partners. We work at national level and about 13 states, select cities, and really looking to see, how we can improve primary healthcare. That's going to be important. In the urban system, all of you are aware that the urban system does not match the rural system as far as healthcare is concerned. Simply because of the large private sector that's available and hence the out-of-pocket. The healthcare innovating financing platform that I spoke about earlier. Collaborations with civil society, private sector, academics, foundations, and governments to respond to the COVID-19 pandemic taught us many things, that you can also do those kind of collaborations in the real world or during non-pandemic times, which could be crucial. And at the same time, look to see how you can bring down costs or share costs in tertiary and secondary care institutions, especially for critical care management. Next, please. So, I mentioned Utkrisht. You all may have seen that earlier, the Utkrisht Development Bond. Mainly worked in Rajasthan, and, we're able to provide services to 405 hospitals, which were basically private maternity hospitals, and built their capacity to enable them to have quality certification. And during that period of time, almost 450,000 mothers and neonates benefited by that quality. And once the facility reached a certain standard in terms of quality, that's when they were paid for their services. And so we are actually able to improve that through various sources of funding. Bottom left, loan portfolio guarantee through IndusInd Bank, where the hospital commits, the bank commits at least $9 million with backing of USAID funding. And, they are able to, the implementer is able to provide service to over 550,000 patients, and ensuring that, the loan can be wiped out with ease. So really at the end of it, nobody loses. The bank gets their money back, patients get the benefit, facilities are now benefited because their standards of quality have improved. And USAID is just happy to support such thing. On the right top, Mukti is a pay-for-performance model that we tried in a small district in Madhya Pradesh, Dhar, where, we look to just, one indicator of can a person gain 6 kgs of weight, at least 6 kgs of weight during the course of treatment, 6 months of treatment, 1 kg a month. And, we provided them nutritional support in addition to ensuring treatment adherence. What we actually found was that almost 70% improved by 10 kgs. And more importantly, there are very few relapses. So I think TV is moving in that direction, wherein you'll probably have less of, follow-up issues if you ensure that nutrition is a part of that. I apologize, excuse me. Samrid is something that's new, and you all can Google this, samridhealth.org. we have pumped in just about $30 million, and we have commitment from the private sector of 10x, so almost 300 million will be pumped in by private sector. But this is to take solutions that can go to scale, and it ranges from med tech, through oxygen, through providing healthcare services of them, subcontracting or innovative financing. So it's an impressive idea. They're working with the Atal Innovation Mission and other such government agencies to be able to take this to scale. Next, please. Private sector, we spoke about this earlier, and I spoke about the corporate TV pledge. So what you're seeing on the right side are some of the members of the corporate TV pledge. We also have a private sector engagement strategy that we have finalized, and we have a separate organization there. Like I mentioned, the corporate TV pledge, it was 120, this is a few months ago. It's now 215. And almost 5 million individuals with TB have now information and services. And it is owned and run by the Ministry of Health and Family Welfare. And this is really what, the success story. You can actually access this website on the government website, from the government website. So it's not owned anymore by USAID. It's actually owned by the government. The Caring CEO Forum, we spoke about it, where a large number of companies supported COVID-free workplaces and COVID-free communities. We also have large players like Unilever and Essilor, who supported areas of hand washing and integrating eye care services within health and wellness centers in the state of Odisha. It's pretty brilliant, and that's probably going to go to scale, where you can actually get your powered spectacles tested at home and delivered to your home as well. And then, of course, we have a PSE accelerator mechanism that focuses on resource mobilization, market shaping, and strategic PSE collaborations. It was for COVID, but we'll be expanding it to other areas as well. I think that's it. Next, please. Yeah, no, and we can leave this slide on, but it's just basically the areas that we work in, and that's about it. So I'll stop here. I'll look to see if there are any questions. We have about 10 minutes, and I don't want to go over, but I'll be happy to take as many questions as you want. So I'm looking at the first question. Do you want me to go through the questions, Dr. Aradhita?
Right, yeah, we can do that. I can go through it for you. So the first one, if we can see, is from Dr. Rajesh Pandey. Thank you for sharing the know-how about USAID and its mandate and focus areas. Was wondering whether there is something specific USAID is planning in alignment with Government of India Goal TB 2025, TB elimination by 2025.
So thank you, Dr. Pandey. So we work very closely. So the Ministry of Health and Family Welfare, they have something called the Central TB Division. They're the ones who run the National TB program. So like I mentioned, we actually have a technical support unit placed at the Central TB Division that provides support with them. We are fully aligned with the goals of the Government of India, and we provide support there. And then we also have partners on the ground who are able to take any of the suggestions that are coming from the government to be able to support them. So we are fully engaged with them. In fact, we are the largest bilateral donor supporting the Government of India in this space of TB. Thank you. Next.
So the next question is from Ziliana. What is the nature of partnerships USAID does with Indian government partners? Is it match funded or other forms of partnership?
Great question. Thank you. So, I think, like I said earlier, right, we were seen as just donors, right? So, you are asked to put your money in a certain area, and it could be as redundant as, in the early pre-internet days, just print modules and things like that, right? But over a period of time now, what has happened is that we work so closely, and because we work so closely with the government, we are ensuring that there is no overlap, no duplication. So for example, let's say we go to Madhya Pradesh and say we'd like to work in these two districts. The government tells us don't go to these two districts because the so-and-so partner is already there. So then we quickly say, okay, then what would you suggest? And so they will suggest you go here, there is no partner there and we need support there. And so that's how we work with it. So, so we bring in our own technical assistance, bring in our own funds, we bring in our own partners, and we ensure that, this is what the government wants to do and see. It's purely dependent on what the government, both state and national, would like to see. And that is what we do for them. So we don't match funds directly, but really it's this simple method of bringing in a niche partner. So for example, we have a specific partner that works on artificial intelligence. They're more at national level. We have other partners who work on community engagement. And so, you don't want the community engagement partner to start talking artificial intelligence. They can't. They don't have the capacity. They're great at what they do, and hence we expect them to do that. So if a particular state wants support in community engagement, then we are able to request that partner to be able to provide support to that state government. So that's how we work that. Thank you. Next question, please.
So I'd like to ask something related to this. When you mentioned about Samrid in one of your slides, so Samrid is some.
I'm sorry, you're breaking up. I can't hear you.
Something that you would that you talked. You talked about Samrid in your slides, right?
Correct.
So the funding in Samrid, that is got in what respect? By match funding or by talking or interacting with individual partners or collaborators? And
okay, so I think I get your question. So like I said, we've committed about $30 million. What will happen is that we look at various innovations that are available in the market, right? And we get other sources of funding who also show interest, right? So so for example, there's something called Black Frog Technologies. They have actually they've built vaccine carriers, right? So so we are able to say that is there someone who wants to come in and support this? So ours is only 10% of that funding. Right. So we don't match funding. In fact, we provide very little funding for mainly seed funding or catalytic funding. And that way we're able to bring in many more innovators to be able to provide that support. I hope that answers your question.
Right. Thank you. So the next question is again from Dr. Pandey. Learning from successes of SARS-CoV-2 surveillance, is it being considered to be supported by USAID for MTB genomic surveillance, especially with role in MDR detection?
Thank you, Dr. Pandey. Great question again. So, I think, in this whole genomic surveillance space, we have, I think, about five WGS, whole genome sequences that are in play that we've supported the government with. But with our COVID funding, we have another 12 that's being set up at various state levels based on the request of the government. So at a certain point, yes, the whole genome sequencing needs to become a part of the national TV program. We have this organization called Foundation for Medical Research, based out of Mumbai, and they're the ones who are the lead on this. And they are providing both technical capacity building of these institutes that have these whole genome sequences, as well as ensuring that surveillance now takes on a much bigger role to ensure that we are able to support the government. Thank you.
Thank you.
Next question.
So the next question is in India can get engaged with USAID and its work.
Okay, I think there are two questions which are similar. So I'll try and answer them both together because they're both research related.
How do the researchers access funding opportunities?
Correct, right, okay. So what happens is USAID per se goes through a process by which we select these. I keep talking about partners, right? And you saw 40 partners, 9 partners, 6 partners. So that's a long drawn process. For us to select a partner, it will take 12 to 18 months because that's how long our process is. So what happens is once we have done that and we have the partners on board, then within the partner mandate, some of the partners have research as part of their mandate. All right. And so, when they start doing that, there could be a possibility that they put out an RFP and ask for, researchers to access funding to be able to provide that kind of support. So, so what I would suggest is for you all to look out, various platforms are there that USAID puts out its RFAs. I think as an organization, you all should be accessing that. And, that way, then share it widely amongst your own group so that, people can access those research opportunities. At the same time, we'll be able to share partners that have ongoing research mandates so that, you can look towards that. The government of India, especially, I speak on the TB portfolio, they support a lot of research. So if you go to the TB website, which is tbcindia.org, tbcontrolindia.org, you'll actually find the priority research list of priority researches that they would like people to do. It's mainly targeted at medical college students, but if you all are interested and you'll see an opportunity there for something that you all can do, we're happy to do that. We work with all the research institutions, especially ICMR. We have National Institute of Research for TB, for example, down in Chennai. We have the National TB Institute in Bangalore. Here in Delhi, we have the National Institute for TB and Respiratory Diseases. So we're working with all of them and in various types of researches. But like I mentioned, it's not basic research. It is operational research. So I hope I'm able to answer that. Last question on the chat.
Thank you. Last question on the chat is from Dr. Kumardeep Chaudhary. He asks, great overview of the work. What are the support planned for a research lab who is interested in AI solutions for AMR, TB, or other pathogens? What is mode of application for some funding?
Thank you, Dr. Chaudhary. I think at this point, my immediate answer is no, because right now we ourselves are building this portfolio. So we have a large technical support unit that works. So you all can Google Wadhwani Institute of Artificial Intelligence, WIAI. They are the ones who are doing AI for social good. So basically, they have no proprietary on anything. We support them. They have their own core fundings as well. The Wadhwani brothers are big guns in the US that made their billions during the IT era, and they are now using a lot of their profits for social good. And so we work with them. But what is happening is, in the process, the government would like us to build Center of Excellence for AI in health. So right now, we've started talks with the All India Institute of Medical Sciences as well as IIT Delhi to see how we can set up the Center of Excellence. So there's no funding that anyone can access at the moment. But, you make a good point. I think, over a period of time, we should get to that. But, just I think as a teaser, a lot of interesting things. So, for example, can you diagnose TB through cough? So cough sounds. So, we've now collected over 5 million cough sounds, and research is ongoing with that. And over a period of time, we'll have algorithms that will actually be able to help us diagnose early tuberculosis through just a cough sound. So it's there and it's happening. And, but I'm sorry, at the moment, there's no funding that's available for AI, at least not from us. But I'm sure things like BIRAC or other such places are ones that you should be reaching out to, because I think almost every 2 weeks they put out a call. I don't know if they do anything on AI, but I'm sure there's something that would be of interest to you. Thank you.
Thank you, Dr. Swamickan. Yeah, we were aware about the cough sound research that you were talking about with the Wadhwani brothers. In fact, for the COVID part of it, we were associated with them also in that part of the work. Yeah. So yeah, maybe Kumardeep can take a look at that angle also. Right. I don't see any further question on the chat or on this question answer block. Thank you so much, everybody, for participating and for your time. Dr. Swamickan, I know you had a busy schedule and we somehow just managed to do this. And look forward to, working sometime in future sooner.
Please, yes. No, and, I'd be happy to take any more questions if you have. My email is available.
If there's anything, please do type in.
Yes, and I think if anyone else has questions that you think of later and you want more information, please don't hesitate to reach out. We'll be happy to do that. And, and in the long term, if you all see value, because research is an important topic. Sorry, one thing I didn't mention, and maybe, there's a new research project that's come out from Washington. It's called SMART for TB, SMART for TB. I just heard of it yesterday. I myself haven't gone through it. but it's all about research. So maybe you all can look at it since it will interest you all. Smart for TB. I will try and find more information. And if I do, then I'll share it with you all so that you all can see what are the opportunities.
Yeah, that would be really nice. Was that an aftermath of the the recent visit of USAID to India, like something?
No. So like I said, like I said, our procurements take 12 to 18 months. So the visit was recently new in this. I'm typing my email in the chat. I think somebody wanted my email.
Yes, I wanted it, right?
So that's my email address. So please feel free to reach out if you have any questions. I'll be happy to take them and answer it for you, or at least help direct you to the right person. So if there's nothing more, and I just thank you all for your time. It's pretty valuable, and on a Friday evening for you all to think. But you all are researchers, so you all think only science all the time. So I suppose it's fine with you all. But thank you for taking the time, and more importantly, thank you for allowing me to say a few words about our organization. We'll be happy to reach out again.
Thank you so much, Dr. Swamickan.
Thank you, everyone. Thank you. Bye-bye.
Bye-bye. Have a nice weekend.